So how about giving back the whole microbial ecology? Because the gut microbiome, as you'd agree, is an ecological system. And if we give a small part of the ecology, it may not work. And that could probably show the variability of the results in the different evidence that I had shown. So the other thing is we can give back the whole microbial ecology in the form of fecal microbial transplantation. So if we look into the history of, it is very old actually. Even my talk is about the present and future. This is the past. So even at 4th century BC, the Chinese guy called Ji Hong actually prescribed fishes for patients with food poisoning or diarrhea. And during the Second World War, it was camel stool was taken by the people for bacterial dysentery. If you see the animal world, you can see this elephant just having poop directly from the anus. So this shows that fecal microbial transplantation has been there since very long. So now it has been evolved as a specific discipline with lots of criteria and lots of new technology development. So the 3 prerequisites for the FMT or fecal microbial transplantation, that we need to have a donor, healthy donor. There has to be a good stool preparation and of course the recipient or the patient. So the donor can be any healthy family member or a friend or an office colleague, anyone. And a new concept is coming up called a super donor. I'll come to that a little later. But before we select the donor or collect stools from the donor, they have to be thoroughly evaluated for presence of transmissible disease and factors like intake of antibiotics, probiotics within the past 3 to 6 months of the donation. Stool prep. This is a very important factor, and this is actually very easy. You can do it in your kitchen also. Just you can take around 200 grams of stool, mix with normal saline, and this is a normal grinder and juicer that you use at home, right? So you can just stir it and then filter it out, and the suspension that you get is the stool. So you can make it at home, right? And then the donor. So how to administer it? So of course, one easy route is the upper GI endoscopy. You can put in an endoscope through the mouth to the duodenum and then inject the preparation. But again, Dr. Ghoshala said it may not be very good. So the other route is a colonoscopy. You can go from bottom. So you put in an endoscope and go up the colon. This is the descending colon. And then you can put it in the cecum. So what we do while we take out the scope, we continuously inject so that the whole colon is we will give the fecal slurry to the whole colon. And now technology have developed where we can have stool banks. The US people who are selling it at the high price, they take the stool samples and store it at -80. That's it. And then you can anyone can go like going to a shop and you can give me 1 kg of stool, and you give a high price, right? And then a new technology is coming up where the stools are being capsulated. So they make stool capsules, and the patient has to take like 12 to 14 capsules 2 to 3 times a day. And the other new technology is they're making artificial poop. They're making artificial stools by using different fermented products, which are supposed to contain the good bacteria. So these are the evolving technology how you can treat a patient with fecal microbial transplantation. So who are the recipients? There are several studies again. And the most strongest indication where the best benefit, again, with fecal microbial transplantation is Clostridium difficile diarrhea. Even with probiotics, Clostridium difficile diarrhea showed the best treatment benefit. And there are other diseases like ulcerative colitis. Have you heard of ulcerative colitis, Crohn's disease? Inflammatory bowel disease, basically? Yeah. Then irritable bowel syndrome, you saw lots of slides from Dr. Ghoshal. Alcoholic liver disease, autism, metabolic syndrome. So if you see the size of the font, it indicates this is the best indication, and the strength of evidence becomes low as the list comes down. So let's look at some of the evidence. So this is how Clostridium difficile look like. So it happens in patients who are using several antibiotics for a long time. It may happen in patients with ulcerative colitis. And if you see here, This is the patient on day 7. Then again, they looked at the microbes at day 0. This is the donor on day 0. So when it was transplanted to the patient at day 7, this changed to almost to the donor fecal microbiota, right? And it persists to up to day 33. So the diversity changes and it acquires more of the donor diversity. So that indicates that the gut microbes are being changed after fecal transplantation, and that correlated with the clinical symptoms. And this is another very good paper from New England Journal of Medicine, where if you see here, compared to the antibiotics that are used for Clostridium difficile, infusion of donor feces resulted in significantly higher benefit in these patients. And again, as I said, like level 1 evidence, meta-analysis, which are supposed to be the best quality of evidence in literature. So even in this meta-analysis using only non-randomized control trials, that was pretty old, 2013. And recently, 2018, there was another study where they have used studies having randomized control trials. So randomized control trial in clinical research is supposed to be the best form of trial. So even in those randomized control trials, there was a significant benefit in these patients having Clostridium difficile after fecal transplantation. So what about inflammatory bowel disease? Again, I won't go into the details of the pathophysiology, but let's see some images. So these are 3 different cases, patients, and they had very bad intestinal disease, lots of inflammation, swelling, pseudopolyps, patient had diarrhea, blood in the stool. So this was before fecal transplantation, and this was after fecal transplantation, drastic difference. And these patients were not responding to the conventional treatment. So when fecal transplantation was given, they had a significant benefit. Similarly for this patient, so dirty looking, like it's scary. Like for the non-medical person, it would look scary, right? But after fecal transplantation, there was significant improvement. Similarly with this patient, there was significant improvement. But again, we need evidence. These are just case reports, 1 or 2 case reports. So what is the evidence? There has been 2 good quality studies. One is a systematic review in 2017, and in 2018 there is another Cochrane systematic review using only the randomized controlled trials. So what the summary of these 2 studies, like they had combined many studies and did the analysis together, pooled analysis. So the problem is this was tried only in ulcerative colitis, not in Crohn's disease. Patient did not have very severe disease. So the patients were having mild disease, and number of studies are low, only 4 randomized trials, and there are no data on long-term efficacy. Quality of evidence is not great, but so it's very difficult to definitely say that yes, it definitely helps the patient. So more studies would be required to come to a clinical decision or clinical consensus. But if we look at the study published in Gastroenterology like 3 years back, in these patients, like they had ulcerative colitis and fecal transplantations were given from 8 donors. And if we see the patients who received from donor B had the maximum benefit, right? So if you see the diversity of this guy, this donor was the maximum. He had the maximum diversity among all the 8. So this is what I was talking about, super donor. A donor which will have the best diversity that can be used repeatedly again and again. His stool can be stored for later use. So this is the concept of super donor. Again, irritable bowel syndrome, we heard a lot about irritable bowel syndrome, where gut dysbiosis was associated with different symptoms of the patient, diarrhea, anxiety, early satiety, sort of thing. And then lots of studies have shown some benefits, some studies, mostly case reports. But if we look at the high quality evidence, like randomized controlled trial, there were divergent results, right? So in one of the studies published last year in January, patients receiving fecal microbial transplantation had shown better response compared to placebo. Placebo means they are not getting anything or some different treatment. So they showed better benefit, but the paper published later in Gut showed that gut microbiota improved in the fecal transplantation group, but clinical response was better in the placebo group. So patients who were getting the fecal transplantation did not have a good clinical response. So again, the evidence is divergent. So if you look at the adverse event, they do not have any major adverse event. Minor event might happen on the day of transplantation, like abdominal cramp, constipation, diarrhea. So these are very minor side effects, but so it's a safe procedure. But the evidence-wise, we have only compelling evidence to prescribe it to patients with Clostridium difficile. For the other indication, we need more data. Okay, so I'll skip this one. So what I just talked was the past and the present, and I have not touched upon the antibiotic studies. You had already heard about the use of antibiotics in hepatic encephalopathy. Treat them with antibiotics. Next morning, patient wakes up and talks to you. Again, there are other studies with IBS, diarrhea, predominant IBS from Dr. Ghoshal's group, who have shown that antibiotics could improve the symptoms of IBS diarrhea, like using specific kind of antibiotic, not all types of antibiotics. So what lies in the future? I think here, scientists sitting here can come into play. So the future is actually here. So we live in the era of precision medicine, right? All of you know about precision medicine? So when we talk about precision medicine, most emphasis is given in the genomics. Like we have a known genome, we can do a genome analysis, we can find out the mutant gene or single nucleotide polymorphisms, and based on that we can treat or design treatment for this patient. But the problem with this is genomics, we cannot change your gene. Except for very minimal indication, you can use CRISPR-Cas and change your gene, but not by and large. But the beauty of metabolome and microbiome is we can manipulate the microbiome, right? So I think precision medicine would be complete, or it is incomplete without including microbiome. And Dr. Ghoshal had also said microbiome is the main element that determines your disease, right? So microbiome metabolome interactions has to be included in precision medicine. And this actually has been done, so the future is already here. So if you look at Science last year in the same issue, January issue, there were 3 papers who looked at the gut microbiome, how it affects the immunotherapy against epithelial cancers and malignant melanoma. So if we summarize the results of this study, if you see here, the patients who responded to the immunotherapy, anti-apoptosis-based immunotherapy, the responders and non-responders had a different group of, or discrete group of microbes. And if you see this Kaplan-Meier curve, the patient who had responded, like progression-free, or they did not progress or did not die, or improved in their outcomes, they had a higher abundance of Faecalibacterium and Bacteroideales. The patients who had lower Faecalibacterium Bacteroideales, they died early or they did not respond. The same changes were also seen in the metabolic profile, which means that specific microbes impact the survival following immunotherapy in melanoma. And this has been extrapolated to several other cancers like urothelial cancer, small cell cancer of the lung. And if you see this Kaplan-Meier again, patients who received antibiotic, in spite of the PD-1 therapy, they had a shorter survival, which means that by antibiotics, you are killing the commensals or the host microbes, and an altered gut microbe or dead organisms or lowering of the diversity reduces the response of the cancer. So which means that gut microbiota is very important in the response to immunotherapy. So again, this is the summary. So why does it happen? So they went one step ahead to see the mechanism, what happens. So what they did was, they took stool samples from the non-responder and responders and did a fecal microbial transplant in these germ-free mice, and then they put the tumor in them. And the patients who did not respond, the tumor here was also having poor response. And there was increase in CD4 Treg cells. On the other hand, in cancer, we don't need too much of Treg. Treg are anti-inflammatory. So we need more of inflammatory cells in the cancer milieu. And when the responder stools was injected into the mouse, there was an effective response and there was an increase in CD8 T cells. So this indicates that gut microbiome can modulate the immunotherapy or the immunological environment that goes inside the intestine, and that can affect the results. So there is another thing called the precision editing of gut microbiota. So again, I had already talked about ulcerative colitis, and there are many mouse models where you can induce colitis and do different kind of things. So what in this study, the authors looked was, They induced colitis in a mouse model using something called DSS, and W is tungsten. So they gave different treatments. One is a sham group, one is a tungsten alone, one is the colitis, one is colitis with tungsten. And if you see here, when they looked at the microbiota of the group with the colitis and tungsten model, the diversity was much more. And as Dr. Hoshal had already said, more diversity is better for the health, right? So what tungsten treatment did was it prevent dysbiotic expansion of Enterobacteriaceae. So the bad bacteria did not grow much in the presence of tungsten. It reduces the severity of inflammation, and the mechanism was it selectively inhibited molybdenum cofactor dependent respiratory pathways. So this opens up a wide field to manipulate this gut microbiome using different kind of treatment, and then increase the response to some other treatment. And the gut microbiome actually is responsible for metabolism of several drugs. So now it has been known that more than 60 drugs are metabolized by the gut microbiome. It's very plastic. So there has been studies, I have not put the references here, but the efficacy and side effects of many drugs are directly affected by the microbial metabolism, like paracetamol metabolism of anti-cancer drug. Many anti-cancer drug causes diarrhea. So the diarrhea is actually mediated by the gut microbiome. They can inactivate digitoxin, a cardiac drug. They can cause adverse effect related to antipsychotic medication. So this means that if we can manipulate these organisms, the specific organisms, then these side effects could be averted. So it's critical to microbiome and metabolome in the algorithm of precision medicine. And then based on artificial intelligence, mathematical modeling using genomic data, metabolome, microbiome data, clinical data, we can specifically tailor-make treatment for individual patients. So I think I'll stop there and I'd be happy to take questions. Thank you.